Good evening and welcome to the 11th edition of the ERS Vision Live panel discussion featured exclusively on the ERS Respiratory channel. Today's discussion will focus on the management of acute pulmonary embolism. The talk will be broken down into 3 parts in which the panel and speakers will discuss the first steps in caring for a patient with acute pulmonary embolism, the recent evolution in the management of anticoagulant therapy for patients with pulmonary embolism and cancer, and finally, what we can expect from more advanced therapies in patients with acute pulmonary embolism. We are delighted to welcome today's panel led by Professor Laurent Bertoletti and Professor Remedios Otero. Professor Bertoletti is a chest physician and head of the vascular unit in the University Hospital from St-Etienne in France. He is the national coordinator of the RIETE registry, the larger ongoing registry of patients with venous thromboembolism. His research focuses on the management of vascular diseases, particularly pulmonary vascular diseases. Professor Otero is a pulmonologist in the Hospital Universitario Virgen del Rocio of Seville in Spain and head of the group of experimental laboratory respiratory diseases in Biomedicine Institute. For more than 20 years, her research has focused on pulmonary embolism prognosis and home treatment, chronic thromboembolic pulmonary hypertension, cancer-associated thrombosis, circulating microvesicles, and biomarkers. Good evening, Professor Bertoletti and Professor Otero.
Good evening.
Hi, Meg. Hi, Laurent.
It's lovely to have you here with us tonight. Joining us to help elaborate our introductory topic of discussion, the first steps in caring for a patient with acute pulmonary embolism, is Dr. David Jimenez Castro. Dr. Jimenez is Associate Professor of Medicine at the University of Alcalá in Madrid, Spain, and Chief of the Venous Thromboembolism Program at the Ramón y Cajal Hospital. His interests include venous thromboembolism and clinical care, education and research for patients with pulmonary embolism. Good evening, Dr. Jimenez.
Hello, everybody. Thank you for the kind invitation. It's a great pleasure to be here with you all today.
Thank you for joining us today. So to start this section off, Dr. Jimenez, acute pulmonary embolism is the 3rd cause of cardiovascular death worldwide. What are your thoughts on this?
Well, absolutely right. Pulmonary embolism is still a worldwide major health issue. And we as clinicians need to be updated and need to be aware of a broad range of best practices, including appropriate triage of the level of care, evaluation and delivery of reperfusion therapies for severe pulmonary embolism, and of course, the very fancy multidisciplinary pulmonary embolism response teams, the PERTs.
David, it's great to have you on board. Many thanks. According to your very personal experience, what are the very first steps when a patient is diagnosed with acute pulmonary embolism, let's say PE?
Well, I think that the first step is even before the patient is diagnosed with pulmonary embolism, because you know very well that diagnostic algorithms are a little bit different according whether the patient is stable or unstable. But when the patient is finally diagnosed with acute symptomatic pulmonary embolism, in my opinion, the 2 mainstays are risk stratification for short-term complications and assessment of the bleeding risk.
Thanks, David. So let's imagine a patient with a good hemodynamic status. He has a confirmed PE, and so it seems crucial to properly assess patient short-term prognosis first, as you said. Can you briefly explain us why and how we could do this, please?
Well, risk stratification and assessment of bleeding risk help select the best therapy, which might be only anticoagulation versus reperfusion, or sometimes the insertion of an inferior vena cava filter, and better determine the level of care. Some patients have to be in the intensive care unit versus a step down or the regular floor, or even there are some patients with a very low risk for short-term complications who might benefit from home therapy of their disease. And we have different tools that allow prognostication, such as clinical scores, the PASI, the simplified PASI, the HESTIA criteria, lab tests, and imaging testing. Clinical practice guidelines, such as the European Society of Cardiology 2019 guidelines, have proposed algorithms that combine these tools for risk stratification of patients with acute symptomatic pulmonary embolism.
Great, this is crystal clear. So once we have differentiated patients with good prognosis, for example, those with a low risk of death and a low risk of bleeding, from those other with a worse prognosis, how does it impact our management in clinical practice?
Well, first, low-risk patients with acute symptomatic pulmonary embolism might benefit from early discharge or even outpatient therapy of their disease. But it is important to also identify the sickest normotensive patients with acute symptomatic pulmonary embolism, the so-called intermediate high-risk subgroup of patients, because these patients benefit from monitoring. This is what we learned from the PATHO trial. And some of these patients might benefit from advanced therapies beyond anticoagulation. The PATHO trial did not find a net clinical benefit for systemic full-dose tenecteplase, but some of these patients might benefit from reperfusion therapies such as percutaneous thrombectomy or even low-dose systemic thrombolytic therapy. And we need randomized controlled trials to answer these questions.
So thank you for the interesting discussion, David. Laurent. I invite the online participant to ask a question to real expert. And waiting for question from the audience, I would like to state that we all know the prognostic stratification of pulmonary embolism from the clinical guidelines. But in your opinion, what would be the points for improvement? David?
Yeah, I think that we have room to improve our prognostications of patients with acute symptomatic pulmonary embolism. First, we have not still defined the thresholds for identifying patients with low-risk pulmonary embolism. What I mean is that which is an acceptable risk for short-term complications to send a patient with low-risk pulmonary embolism home. It is less than 1% during the first 30 days. It is 0.5%, it is 0%. And we have to refine the combination of tools to identify these patients. And number two, in my opinion, I think that the subgroup of patients with intermediate high-risk pulmonary embolism might be refined. Not every patient with intermediate high-risk pulmonary embolism, according to the clinical practice guidelines, which is right ventricular dysfunction plus myocardial injury, are the same. And I think that we have the opportunity to identify the sickest patients with pulmonary embolism in this group. And finally, I think that we have some room to improve our cutoff points for different prognostication tools according to whether we want to identify low-risk patients or intermediate high-risk patients.
Thank you, David. We have a question from the audience. The prognostic role of ERS score in identifying a pulmonary embolism in hospitalized and outpatients. What is your opinion?
Well, I'm not sure if I understood the question, but we have to differentiate between those scores which are intended to diagnose pulmonary embolism, such as the Wells score, the Geneva score, the ERS score, the PERC score, with prognostication scores, such as the PASI, the simplified PASI, or the HESTIA criteria. I'm not aware of any study which used the ERS score, which is a diagnostic score, to prognosticate patients with acute symptomatic pulmonary embolism.
There are another question from the audience. So how would you manage finding of incidental segmental pulmonary embolism in a patient admitted with community-acquired pneumonia, for example?
Well, that is an interesting question. I'm not sure if Cecilia is going to touch on this in a couple of minutes, but anyway, in my opinion, the first step is to differentiate between incidental asymptomatic or symptomatic pulmonary embolism, because for patients with incidental symptomatic pulmonary embolism, the problem is that clinicians were not good enough to diagnose those patients. So management is exactly the same as for patients with acute symptomatic pulmonary embolism. For patients with incidental asymptomatic pulmonary embolism, I tend to treat the same step for those with multiple subsegmental PE. For these patients, most of them are sent home with low molecular weight heparin or with direct oral anticoagulants.
Yes, I think we will back to the incidental pulmonary embolism later. Other question is any recommendation of anticoagulation strategies for patients who develop pulmonary embolism on existing direct oral anticoagulation or warfarin?
Well, you know very well that clinical practice guidelines, both the ESC 2019 and CHEST 2021, recommend direct oral anticoagulants for the vast majority of patients diagnosed with acute symptomatic pulmonary embolism. There are a couple of exceptions. Number one, those patients with severe renal failure, creatinine clearance less than 30 milliliters per minute. And number two, those patients with known antiphospholipid syndrome. Once said that, in my clinical practice, I tend to use direct oral anticoagulants for the majority of patients with acute symptomatic pulmonary embolism if they are low risk or intermediate low risk. For those patients with intermediate high-risk pulmonary embolism, and these patients might deteriorate and need reperfusion therapies, I still tend to use low molecular weight heparins for the first days after diagnosis. And for patients with unstable pulmonary embolism, those with high-risk pulmonary embolism, I endorse the use of unfractionated heparin before and during the use of reperfusion therapies.
An interesting question from the audience. I'm curious to know the opinion from Stavros or from Oliver Sanchez or Cecilia Beccatini. We are agreed that we have to discuss the rate of events which should be acceptable to propose outpatient management. But which event should we include in this reflection? What is the
could you repeat what was the question? Which score or what was the question?
Laurent,
reformulate.
Yes.
David told us that we can first discuss which rate would seem acceptable for outpatient therapy. But the question is, which composite endpoint do we want to assess as acceptable? Do we assess only patients at low risk of recurrent PE, or do we also include, for example, those who will have major bleeding?
I may start with the first answer and then ask what the other colleagues think. So until now, in studies on the management of acute pulmonary embolism, the standard outcome used in most of the trials and most of the prospective studies was somehow a composite of recurrent symptomatic VTE or fatal PE. Usually at 3 months. This is the standard. In some studies on home treatment of PE, this has been used in one study. In another study, it was on a shorter period of 1 month. This can be discussed. It must be clear that, of course, overall, and this is how also the ESC and ERS endorsed guidelines see it. First of all, the risk of the patient overall must be low, because to send the patient home, the patient must not experience an adverse event, and a fatal or a dangerous adverse event over the next days. So one might discuss if 1 month is enough for this purpose, if one should look for 3 months. I do not believe the difference is so huge. So we can take either. And then, of course, and this is clearly where we have the superiority, let's say, some advantages of the more practically oriented Hestia criteria, the criteria for a home treatment that also have been tested and used in the home PE study. Then the question is, of course, not only who is about to die or experience a recurrence, but also who is free of such severe comorbidity and has the social and family background to support her or him to be treated at home. So I do not think that it is so critical to change the primary outcome. We can leave the primary outcome in order to permit conclusions with historical comparisons with historical data. But it is also, of course, important to validate also other patient-related outcomes, and also to validate, of course, and show that the energy expenditures on the part of the healthcare system are much less.
Mm-hmm. Thank you very much to all. We have run out of time for this first session. There are a lot of questions in the audience. This discussion has stimulated the interest of many online participants, but Miv has the floor now.
Thank you so much, Remedios. And now to the next topic of discussion, the recent evolution in the management of anticoagulant therapy for patients with pulmonary embolism and cancer. We welcome Professor Cecilia Beccatini. Cecilia Beccatini is Professor of Internal Medicine at the University of Perugia in Italy. She is involved in national and international research projects in the field of prevention, diagnosis and treatment of venous thromboembolism and cardioembolic events in patients with atrial fibrillation. Good evening, Professor Beccatini.
Good evening, Mahir, and good evening to all the attendees. It's really great session and great to be here with you today.
Well, it's certainly great to have you here with us today. So to start the second section off, venous thromboembolism is a common complication in patients with cancer. Current clinical practice guidelines are focused on the general cancer population, but the management in specific subgroups are still challenging. What's your opinion on this?
Well, it's a great question because, as you know, clinical guidelines should anyhow refer to high quality of evidence. And as you know, in recent years, 4 randomized clinical trials have been conducted with oral anti-TNA compared to dalteparin for the treatment of patients with venous thromboembolism associated with cancer. Before of these studies, previous trials compared LMWH, dalteparin or tinzaparin, with treatment with the PKA. And overall, these studies included cancer patients. And you know that an oncologist now is able to characterize cancer based on histochemical and genetic features. And it seems to be inappropriate to include and to define generalistic cancer patients. But as you know, this is what happened for simplicity, for ease of randomization. This was the criterion that was used in clinical trials on anticoagulant treatment. And the more recent studies also characterize the type of patients by including patients with active cancer. So this is another issue. And based on the results of these studies anyway, that were, let's say, designed to include patients with active cancer, from the results of these studies, we were able to identify some subgroups of cancer patients that were more prone to bleeding complications. For example, patients with luminal cancers that were not resected. And also, we should admit that some specific categories of cancer patients were not included in some clinical trials. And this is, for example, the case of patients with acute leukemia or brain cancer. So in this view, maybe that the general definition of cancer patients is inappropriate in 2022, but we know that this is what we have at this stage, but we may also rely on the results obtained on specific subgroups.
Thank you. Thank you very much, Cecilia. About the increasing incidence on unsuspected pulmonary embolism in cancer patients, do you think that this subgroup of patients should be managed differently?
Yeah, again, a good question. And as David was saying before, we have to, let's say, discriminate something like that, patient with symptomatic incidental PE and patients with symptomatic incidental PE. And this is important because probably when we are facing symptomatic incidental PE, we may, let's say, identify the date of this episode. So we know that we probably need to treat this type of episode just like a symptomatic and suspected pulmonary embolism, because we now have a date of onset of the disease. Concerning the incidental asymptomatic, you know that there is discussion in the literature whether we should rely on the presence of DVT, on the level of the dimer. But anyhow, if this is the first diagnosis, probably we need to treat these patients. You know that recently our Canadian colleagues published a study on this specific issue. But we know that as this is the first diagnosis, probably we need to treat these patients as patients with symptomatic PE. And in particular, what we know now is that cancer patients who have incidentally detected venous thromboembolism have probably numerically lower risk for recurrences, but the same risk of major bleeding, especially with symptomatic events. So the issue could be whether we could treat with safer strategies. But as far as we know that the anticoagulation regimens that have been validated until now are the same as for patients with symptomatic and suspected venous thromboembolism.
Thank you very much for your answer. How do you think the use of direct anticoagulants impacts the management of patients with cancer and pulmonary embolism?
Well, my opinion, Otero, is that these are the agents of choice for the majority of cancer patients because of the ease of use and also because of the efficacy and safety profile. I said the majority because we know that some safety issues may be present when we are going to treat patients with luminal malignancies, as it can be stomach or colon cancers or bladder cancers that have not been resected, because in this case, the tumor itself may be the site of bleeding when the patient is treated with an anticoagulant. And in particular, in these specific groups of patients, some caveats may be there. So maybe that sometimes we can decide not to use oral anti-TNA, but for all the remaining cancers, these agents should be probably the agents of choice for the treatment of venous thromboembolism.
Thank you. And the duration of anticoagulant treatment in cancer patients is an open topic for discussion. In which patient would we suspend the treatment with low molecular weight heparin or oral anticoagulants after 6 months?
Again, not an easy question, because as you know, as we are including in clinical trials patients with active cancer, it means that the risk for recurrences remains high until cancer is there. So what usually clinical guidelines report is to treat until cancer is cured. But I'm not an oncologist, but I often discuss with my oncologist, and it's difficult to say when a patient is really cured from cancer. So what I can say is that until cancer is identifiable at imaging tests or is on treatment, then we should consider that cancer is there and that cancer is active. It may be different when cancer has been resected, the patient has been treated, but now cancer is not evident in any imaging testing. So in that case, if anticoagulant treatment has been completed, then we can discuss whether this treatment can be discontinued and the patient may be in a clinical follow-up for symptoms, for recurrences. And as you know, we have a clinical trial that is ongoing on the potential use of reduced doses of oral anti-DNA agents for prolonged treatment of or secondary prevention of venous thromboembolism also in cancer patients. And we are eager to have the results of this trial in order to, let's say, optimize the management of patients with cancer also in the long-term period after the acute event.
Mm-hmm. Thank you very much.
Many thanks, Cecilia. Please do not hesitate to send questions in the chat. The main question at this time is about the duration of therapeutic anticoagulant therapy in patients with cancer. And I think that Cecilia perfectly responded to this question, and we are all expecting the results of the APICAT trial led by Isabelle Mahé from the INNOVTE network and with all the international experts involved in the field. There is also another question regarding intracranial bleeding or situation at risk of intracranial bleeding. So Cecilia, if I remember well, it was not possible to include patients with brain tumor or brain metastasis in the famous Caravaggio trial. Do you have a comment on this question?
Yeah, this is correct, Laurent. Indeed, patients with brain cancer, either primary or secondary cancers, brain cancers, were excluded from the Caravaggio study, while these type of patients were included in the OXIVT cancer study. As you know, anyway, brain cancer patients were a minority of the patients included in OXI cancer. So it is not possible to draw a conclusion for this specific subgroup of patients. In my opinion, but this is my opinion, I think it would be risky to include the patients with active brain cancer, because you know, with LMWH, you may be able to, let's say, adjust your regimen, even though it is not completely correct. But anyway, you may insert a vena cava filter if this is indicated and to reduce the dose. This is not what we now can do with the anti-DNA agents. So I think that if the lesion is still there, it is not treated, not surgically resected, then it may be risky to give the patient a full anticoagulant dose.
Okay,
but still, this is an unmet, I think this is an unmet clinical issue because we don't have enough data to draw any conclusion. I don't know what you do. What do you think?
Fully agree with you. Two other questions. One, I think it will be rather short. Should we stop chemotherapy in acute PE? And if yes, when it should be started again? So the question is that having acute PE, is it a contraindication to propose chemotherapy for the patients?
Well, it's not a contraindication, an absolute contraindication. First of all, it depends on the drug, because we know that platinum agents are strongly associated with the risk of venous thromboembolism. But we now have new agents for which we don't know very well what is the risk attributable to the anti-cancer agents for the occurrence of venous thromboembolism. So it would be incorrect, in my opinion, to say we should always interrupt chemotherapy. Anyway, probably I would not give chemotherapy in the first week, and then I don't know, it's up to the clinician to evaluate the patients, to evaluate the type of anti-cancer therapy that is ongoing, and to keep a decision.
Great, thanks. A very nice question. Do you think that it would be possible to have a biomarker in order to help stopping anticoagulant therapy in patients with cancer?
Okay, concerning the dimer, you know that it would be, let's say, complicated to use the dimer in cancer patients, so I don't think this is the way to go. Whether in the future we will have this kind of biomarker, it is all to come, because we don't have data. Probably we should rely on the imaging and on the clinical situation of the patients, and to be accurate in identifying the, let's say, yeah, that cancer is cured. I think this is the point, because as far as we don't have any biomarker that is usable for this purpose.
Okay, so unfortunately at this time, no validated biomarkers in this field to be able to stop anticoagulant therapy safely. As we are so lucky to have you on board, who are very, very important in the Caravaggio trial. Another question specific to the Caravaggio trial, Cecilia. Caravaggio trial did look at GI tumors. Is it safe to use DOACs in GI tumors as per evidence? It is the question asked in the chat.
Yeah, this is an interesting question, because you know that differently from previous studies with edoxaban and rivaroxaban, in Caravaggio, we didn't observe an increased incidence of major bleeding in patients with gastrointestinal cancers. So what we observed in sub-analysis is that probably those patients with unresected gastrointestinal or urogenital bleeding may have an increased risk of non-major bleeding when they receive anticoagulation. So this is the same point that I was saying before: no increase in major bleeding with apixaban in patients with GI cancer, but some more hematuria and some more non-major bleeding with respect to dalteparin with luminal non-resected cancers. So this is a signal. Probably anti-10A may make the patient prone to bleed from mucosal cancers that have not been resected. And this is something that we have to keep in mind when keep decision in these specific patients.
Yeah, and all the meta-analysis results go exactly in the same kind of results. Great. So maybe if some of my friends in the panel will want to say something. No? So let's move to the next session, and I'm very happy to give the hand over to you, Maeve.
Thank you so much, Laurent. Joining us for our final topic is Professor Stavros Konstantinidis and Professor Olivier Sanchez, who will tell us what we can expect from more advanced therapies in patients with acute pulmonary embolism. Stavros Konstantinidis is Professor for Clinical Trials and Medical Director of the Multidisciplinary Center for Thrombosis and Hemostasis at the University of Mainz in Germany. For more than 30 years, his research has focused on the risk-adapted management of thrombosis and thromboembolism. Olivier Sanchez is Professor of Pneumology at the University Paris-Cité and Head of the Department of Respiratory and Intensive Care Medicine at European Georges Pompidou Hospital in Paris, France. Through the French network INNOVTE, his clinical research has focused on pulmonary embolism, risk stratification, home treatment, thrombolysis, and STEF. Good evening, Professor Konstantinidis and Professor Sanchez.
Good evening. Thank you very much.
Good evening. Good evening, everybody.
Good evening. So to start the third section off, Professor Constantinides, are there other options than anticoagulant therapy for the management of pulmonary embolism?
Thank you. Yes, first of all, we agree that all patients or almost all patients with pulmonary embolism should receive anticoagulant therapy unless there are absolute indications to this kind of therapy, and this is very rare. Having said that, there are patients indeed who may require something more advanced, as you very nicely put it, Maeve, and this is the so-called reperfusion treatment. Reperfusion treatment means that besides preventing new emboli and letting the body dissolve the clots by itself, as we do when we give anticoagulation, we actively try to dissolve this thrombus as fast as possible from the time of that diagnosis. This is usually done when the patient is in a critical condition, so has, as we have put it in the guidelines, high-risk PE. That means there is hemodynamic decompensation or collapse. These types of treatment have traditionally been surgical embolectomy, which is, however, rather rarely needed in acute PE. This has been thrombolysis, which has been and is the mainstay of treatment for unstable patients with PE. Effective treatment, however, associated with a risk of bleeding, which may be substantial. And there are now increasingly catheter-directed options for treatment of acute PE, that is removal of thrombi. And this can be done purely mechanically, so removal, fragmentation, suction of thrombi, or it can be pharmacomechanical, that is some local thrombolysis, catheter-directed local thrombolysis on site. And on the other hand, this may also be or may not be accompanied by some form of thrombosuction. So we do have three additional options: the pharmacological option, thrombolysis, the interventional catheter-directed option, and we have also the option which is the purely surgical one.
Many thanks, Stavros. So now to Olivier. Dear Olivier, it's great to have you with us. So beside antithrombotic therapies, David and Stavros just told us that advanced therapies like Vena Cava filter, pulmonary catheter treatment may exist and may be an option. Can you please remind us the current indication of inferior Vena Cava filters in patients with PE?
Yes, the first thing is that the routine use of inferior Vena Cava filter is not recommended for all patients with acute pulmonary embolism or proximal DVT. And the broad indication of inferior Vena Cava filter is a patient with a proximal DVT with or without pulmonary embolism, but an absolute contraindication to curative anticoagulant. And this is based mainly on the high risk of recurrent pulmonary embolism in this setting and the lack of any treatment options. The other possible indication is the recurrence of PE, the objectively confirmed recurrence of PE despite curative anticoagulant treatment. But I think that this is a more questionable indication of inferior Vena Cava filter.
Many thanks, Olivier. Stavros, so we hear a lot about direct mechanic treatment of the clots directly in the pulmonary arteries. Do we have solid data on such procedure, please?
This question is more complicated to answer than one might think. When we have to deal with devices, and in contrast to drugs, the evidence for validation of devices, the required evidence has been a little bit different until very recently, it is no longer this way, but it was so until very recently. With devices, there are two aspects. First of all, you have to show, of course, that this device can be inserted into the human body, has, for example, in Europe, the CE sign, and does not cause harm. And then, of course, that the procedure can be performed and is safe and does not cause excessive complications. And then, of course, comes the question whether this device helps the patients and improves prognosis. So with regard to the first part, I mean, are there devices that have been developed, are functioning, are safe to use? The answer is yes, we have such devices. We have devices for thrombosuction, thrombofragmentation. We have devices also for pharmacomechanical lysis, either ultrasound-assisted thrombolysis or perhaps also purely catheter-directed thrombolysis on site. So we have such devices. And we also have one more step further, that is, we have studies, cohort studies mainly, in at least two of them, that show that these devices can improve some, as we say, surrogate endpoints in the patient's prognosis. That means we have for two purely mechanical devices, the evidence from cohort studies of about 100 patients, a little more, that these devices generally reduce the right ventricular to left ventricular diameter ratio and can do this quite fast because they actually and actively remove thrombus, and they do it without a substantial risk of bleeding complications because there is no thrombolysis. This is fine. In addition, for the device on pharmacomechanical, ultrasound-assisted pharmacomechanical thrombolysis, we have one small but still randomized control study from 2014 that showed that this device was superior to non-intervention, that is, to anticoagulation alone, in improving, again, the RV-LV ratio. And we have two further cohort studies, or one pure cohort study and one dose-finding phase 2 study that showed that the device worked, and again, that a particular regimen particular regimens were capable of effectively reducing the RV-LV ratio. So to quite a substantial extent, these devices appear very promising and they work well and they are generally safe. And one may discuss whether pharmacomechanical lysis or purely mechanical thrombus removal are the best option. And probably there are patients for whom the former is the best option and the patients in whom the latter may be the better option. What we do not have, however, and this is why guidelines have not yet warmly endorsed these devices, are randomized control trials that we show that these devices, this type of advanced treatment, can directly improve the patient's prognosis. That is, not only improve a surrogate marker like the RV-LV ratio, which is of course good and nice to follow and reproduce and easy to measure, but also that we can improve long-term, acute phase outcomes in these patients in terms of clinical combined outcomes, not just mortality, but prevention of hemodynamic collapse or of hemodynamic decompensation. We are only now starting. There is one study with a device on ultrasound-assisted pharmacomechanical thrombolysis and another starting study with a device on pure mechanical thrombus removal that promise to give this answer. So if there has to be a 100% answer to the question, is that we do not have yet this type. We do have some solid evidence on their efficacy and on their safety, but we do not yet have solid evidence that they can improve the acute prognosis of patients. We expect that, but we do not have it. And this is what we have to expect in the next few years in order to be able to find the exact place of these methods, which can certainly be helpful or life-saving in situations, but we have to formally also validate them as we also validate other means of treatment, such as drugs, for example.
Many thanks, Stavros. It's great to have your opinion on this topic. So for Olivier, I understand that in fact the real indication of such rare this time for the validated one, are there any ongoing studies assessing new procedure in a proper methodological way? So
Yes, of course. Thanks, Laurent, for this question. And our group and that of Stavros conduct the PATO3 trial, that is an ongoing randomized placebo-controlled double-blind and international trial. In this trial, we will include patients with intermediate high-risk pulmonary embolism, combining the classical criteria, right ventricle dysfunction on imaging and elevated circulating troponin, and additional clinical predictors of early decompensation, such as systolic blood pressure below 110 millimeters of mercury, or respiratory rates over 20, or saturation, oxygen saturation below 90% on room air, and history of chronic heart failure. And we think that these criteria, these combined criteria, will select a population of patients at higher risk of early decompensation, who is expected to benefit from early thrombolytic treatment. In this trial, the experimental treatment will be a low dose of alteplase, 0.6 milligram per kilogram on 15 minutes intravenous infusion, and of course both treatment arms will receive low molecular weight heparin. The primary efficacy outcome of the PATO3 trial will be the composite of all-cause death, hemodynamic decompensation, or objectively confirmed recurrent VT, pulmonary embolism, within 30 days after randomization. And the main secondary safety outcome will be fatal or gusto severe or life-threatening bleeding. And this study is planned to include 650 patients in Europe and also in Canada. And we hope to demonstrate a better benefit-risk ratio in these particular intermediate high-risk PE patients.
Thank you. Thank you very much, Stavros and Olivier, for your comments. Thank you, Olivier, for reminding us the absolute indication for Vena Cava filter placement, because there are some several questions from the audience about this topic. For example, in patients with pulmonary embolisms but no deep vein thrombosis, an absolute contraindication to anticoagulation, and this absolute contraindication could be transitory or not permanent. Should we insert the Vena Cava filter?
Yeah, the data demonstrates the useful of inferior Vena Cava filter in patients with proximal DVT plus or minus pulmonary embolism. But I think that we can translate these results to patients with pulmonary embolism despite the absence of proximal DVT, because in these particular patients, the risk of recurrence is quite high, particularly during the first months after the diagnosis. And in case of absolute contraindications to curative anticoagulants, we have the only option to prevent other PE recurrence is to insert inferior Vena Cava filter. And if the contraindication to anticoagulant is transitory, we can use a retrievable inferior Vena Cava filter that can be removed after the contraindication is off.
Thank you. There are some several questions about if there are any ongoing study assessing thromboaspiration or catheter-directed thrombus removal. Now ongoing. Do you know? Yes. Do you know the clinical trial?
Yes, this is true, and as I said, there are indeed two such trials going on. One trial is the HI-PYTHO study. This is a trial assessing the ultrasound assisted catheter-directed thrombolysis device, the ECHOS device. This is a study that has been initiated by investigators, is sponsored by Boston Scientific, and it is a study which is randomized. Let's say it is complementary, if you would like to say. It's the interventional analog to the PYTHO3 study just described by Professor Sanchez. That means patients with intermediate high-risk PE, because it's very difficult to randomize patients with high risk who are in shock. It's not impossible, but it is difficult. So patients with intermediate high-risk PE, this so-called orange PE risk zone, are randomized either to the catheter intervention using this device of ultrasound-assisted pharmacomechanical low-dose thrombolysis on site, or anticoagulation alone. The study has started. It's a study which is running in many centers in the United States and in Europe, has been initiated in both continents, and is recruiting patients. And it is expected to complete recruitment. It is a large study of more than 400 patients with an interim analysis, however, and it's expected to complete recruitment within 2 years. And of course, we will see whether perhaps the interim analysis results will dictate some reassessment, some adjustment of the sample size, or will be enough. We will see all this. And there is also a study using the thromboaspiration device, the flow retriever by Inari Medical. It's the peerless study, which is comparing this device not to anticoagulation, but to local pharmacological catheter-directed thrombolysis with an outcome based on safety and efficacy. And this study has also reportedly begun in the United States. So we will see what these studies will bring. But in any case, the positive answer to your question, Reme, is that yes, we finally have ongoing randomized control trials assessing the clinical efficacy and the safety, but this has also been done in registries and cohort studies, the clinical efficacy of these methods. So we do expect some progress in the solid evidence in favor, possibly in favor, or perhaps not, we will see, of these methods in acute PE.
Thank you very much. Well, this a bit, but the time of the session is finished. I have some question personally, and there are some question in maybe a little bit shortly for Olivier about the PYTHO3 clinical trials. I'm very, in my opinion, the secondary outcomes are very, very important. The persistent dyspnea, functional outcomes, persistent right ventricular dysfunction.
Yes.
Please, a short comment, please.
Yeah, it is very important to have data on long-term follow-up in this kind of patients. And in the PYTHO3 trial, we plan to follow up patients during 2 years in order to assess the risk of CTEPH and other signs such as dyspnea. So PYTHO3 trial will give us the opportunity to have very interesting data on this.
Yes, thank you, great. Laurent has the floor now. Thank you.
Thank you very much, Remedios. So now for the summary, I would be very happy to ask each panelist to give a take-home message on his or her section. First, dear David, what do you want the audience to remember from your section, please?
Acute management of acute symptomatic pulmonary embolism should be driven by risk stratification of the patients.
Gracias, David. Dear Cecilia, from your point of view, what is the key message regarding current management of cancer-associated thrombosis?
That we had tremendous results with the anti-10A in the treatment of acute venous thromboembolism, but please consider to, let's say, stratify cancer patients according to the site of cancer and the bleeding risk.
Grazie, Cecilia. Dear Lieber Stavros, what would you propose to keep as the main message from your section?
There are advanced options for treatment of acute pulmonary embolism, either interventional catheter-directed or purely pharmacological, systemic lysis or surgical. Finally, after many years, we now begin to have state-of-the-art trials, some of which are already ongoing, and which will clinically validate these options, specifically catheter-directed options for fragmenting or aspirating or lysing the thrombi, so that we will see whether they will be a true clinical option for patients with intermediate high-risk PE.
Danke, Stavros. And you, dear Olivier, what would you propose as a key message for your section?
I think that the definition of intermediate high-risk PE will be probably changed a little bit, and we expect to demonstrate a better risk to benefits risk ratio of low dose fibrinolysis in these patients.
Merci, Olivier. So before closing the session, I would like to thank the ERS for the unique opportunity to discuss with the international experts the current knowledge on pulmonary embolism. I would like to thank all the participating panelists, the attendees for the question, and particularly my dear Medelios. Gracias, Reme. Now, Mev, it's up to you. Thanks.
Thank you, Professor Bertoletti and Professor Otero, for chairing this event, and to our speakers for sharing their knowledge with us tonight. And of course, thanks to our online participants today for joining us and for your many questions. A recording of the discussion will be available to rewatch on the ERS Respiratory channel, and the ERS Vision Live series will continue. A new live discussion panel will feature on the ERS Respiratory channel each month, bringing together key individuals to discuss hot topic areas within respiratory medicine and science. We hope you can join us again in May.